Good evening, First Baptist Church family. I hope that you are resting well and that you are safe and healthy and everything is going well with your life. I'm so excited on tonight that we have a very special guest. We had been off for the summer for Bible study, but we decided that since we've seen the numbers with COVID-19 begin to increase in our community, we've had record-breaking numbers. We've gone from 190 to 192. On last Sunday, we saw a number that really shocked us of 256, and as if that were not enough, we recently saw 385 cases, giving us over a 7-day span, roughly an average of about 180 or so cases each day. I thought it was wise at that point for us to come back and begin to talk to our constituency, our congregation, and the city at large. I'm excited tonight that we have Dr. Bruce Randolph with us, who is the Shelby County Health Officer. He is a medical doctor and also holds an MPH degree and serves as the health director for Shelby County. So I don't want to go with a whole lot of introductions. He's a very well-qualified man, been in public health as a doctor and in public health for over 35 years. And so and he's also a pastor. He's also an associate pastor. So it makes it real comfortable for me to have a conversation with him. He has triple duty assignments. He's health department, and then he serves 2 churches as an associate pastor, one in Memphis and one in Arkansas. So thank you, Dr. Randolph, for being our guest on tonight. We're honored to have you. You want to say anything? Tell us a little bit about you and your work and all that you've done and all that you do.
First of all, I want to just thank you, Pastor Norman, for the invitation and the opportunity to come and be a part of this program. I'm a native Floridian.
Okay.
Born and raised in a small town called Live Oak, Florida, and grew up working in the tobacco fields and playing football and going to church, right. And subsequently got a football scholarship at Tuskegee Institute, now Tuskegee University, and from there, upon graduation, went on to the University of Florida for medical school, and Johns Hopkins University for Master's in Public Health, and then I did special training in occupational health at the University of Arkansas in Oklahoma, and have been practicing in occupational medicine for 20 plus years before going into public health. Recently, I started out in public health some 30 years ago.
Well, we met on day one, ground zero, and that was literally the first day we had a COVID case. We met that Sunday morning. I skipped church. We met at the Shelby County Health Department, and we began to learn about roles and what we would be doing. And we've worked together on a task force since that day, literally, to get us to where we are now. Dr. Randolph, you were one of the first people, and I want to drill straight down to what's important to us. You were one of the first people, if not the first, that I heard talking about the impact of COVID-19 on African American people. Tell us what COVID-19 is, what it does, and how it impacts African American people, and why. You can talk all you want to. I'll just sit back and listen.
Well, COVID-19 is the disease that is caused by a virus called novel coronavirus. The scientific name would be SARS-CoV-2, and that's because there's a SARS-CoV that caused SARS earlier, some years ago. So this coronavirus is a new virus that had never affected man before. That's why we don't know a whole lot about it, and that's why many of us do not have any immunity to it. But this virus is very contagious. It spreads through respiratory droplets that can occur when someone coughs, sneezes, shout, talk loud, or sing. And this virus appears to manifest itself within 2 to 14 days after one becomes infected with it. And it manifests itself in several ways. Primarily, it can affect respiratory systems, but we're finding that it affects the heart, the liver, and nervous system as well. And so one of the reasons why we find that among African Americans, we appear to be suffering a higher rate of death is because we have some underlying medical problems. Primarily, when we look at our data, even here in Shelby County, we see that 80% of the deaths that's associated with a comorbidity, it was cardiovascular disease. Now, cardiovascular disease is sort of a broad category because in it includes hypertension as well as heart disease and vascular disease, hardening of the arteries, et cetera. Other comorbidities is diabetes. And diabetes seems to be associated with 35% of the deaths, along with respiratory disease and also renal disease. And so when you look at those four comorbidities, which affect a lot of the African American population, because people who have hypertension or people who have diabetes tend to also have higher risk of cardiovascular disease, kidney disease, and lung disease, especially things like congestive heart failure and COPD. And so that's one of the reasons why my understanding of the disparity that exists, that I noticed, wasn't a surprise because most health problems disproportionately affect African American people because the health problems are really a reflection of other disparities that exist in our society.
So in Shelby County, 54% of the population is African American, but a higher number in the 60s and 70% of the people who have COVID-19 fatalities are African American. So more people are dying in Shelby County disproportionately whom are African American, by and large.
Right.
When I look out over this congregation, an empty room tonight, but I can identify people who have had cancer that I prayed with, people who have heart issues, people who are on high blood pressure medicine. Am I putting them at risk by offering back into mass number and potentially have an outbreak that could impact their lives?
Yes, you would be putting them at the risk because let's look at the average congregation of the African American church.
Okay.
Right?
Yeah.
Many of them are at least 55, 60 plus. Many have some other underlying health issues ranging from obesity to diabetes, hypertension, arthritis, etc. And the issues are the way that we tend to worship.
Yeah.
Is a closeness, you know, shaking hands, hugging, etc., singing. You remember I mentioned that shouting, singing, talking loud can spread the virus. And so people with who are 65 and older with underlying health problems already, what would happen, they may not necessarily be at a greater risk of getting infected, but if they get infected, they are at a greater risk of having complications and dying.
Thank you. That's very good.
Yeah,
that's important.
right,
That's
yeah.
important. So we're going to take that wisdom and we're going to use it because we don't want to put anybody at risk. I want to ask you some specific questions that people have asked of us, and they email some. Asymptomatic and symptomatic. Those sound like real big terms, but they're pretty easy to explain. Share with us what an asymptomatic person is and what a symptomatic person is, and what's the treatment of the two.
Right. So A symptomatic person, if you notice, when you now enter into a building or your work, they ask you some questions. Are you having a fever? Are you having headaches, muscle ache, sore throat, cough, shortness of breath, vomiting, nausea, diarrhea? Those are some symptoms that have been associated with early onset of COVID-19. The more severe symptoms would be things like pneumonia and respiratory distress, and you're not able to breathe because of subsequently having to go onto a ventilator. Whereas asymptomatic is simply no symptoms, and so that means that you are not having any of these symptoms such as headache, fever, sore throat, shortness of breath, difficulty breathing, any of those types of symptoms, but yet you are infected. You still have the virus, it's in you, and you are transmitting it, but you yourself are not sick from it. And that's the danger part, right? And so that's one of the dangers of even having a crowd of people coming together. We know that within a given crowd, as much as 10% of the folk or more could be asymptomatic.
Wow. So even if I brought in the 150 or 60 people that could fit in this room that holds 2,000, some of them could be asymptomatic, and we could still have an outbreak.
Exactly.
Wow.
And pretty much, and that's our fear, and that's why even if you're going to have members come back, you must do some screening up front to try to identify someone who may have that fever, who may even have just some mild symptoms, to try to separate them out. But yeah, there are individuals who walk around, and especially young people. And that's the problem. Young people are not affected by this virus like older people. Young people can get the virus, and many of them, may have some mild symptoms to none,
Right.
and go on and, and do their thing, but they go home.
You just said a very powerful thing. I think we ought to slow that down and say it again. They can be infected but not affected the same way.
Exactly.
So they can have a higher rate of infection or
Right.
the same rate of infection.
Exactly.
But the effect is not the same.
Not the same.
Okay.
Right. And so for them, they may have no symptoms, asymptomatic, or they may have mild symptoms and rebound from it and do fine. But they go home.
Right.
And mama and grandmama can get the virus.
Right.
Daddy or granddaddy can get it. And whereas the younger folks' immune system responded in such a way that they recovered, and an older person who also has some underlying health challenges already, then that virus become a greater burden for them to overcome.
Yeah.
And subsequently, many die.
But if daddy, let's just say I'm daddy, but if daddy lock you out, you can't give it to me, can you? No, if I could
That's
leave you
right.
Okay, I'm just making sure.
Separation.
Separation.
That's
All
the key.
So how would I treat this person? Is the treatment the same? What do you treat with a COVID person? I mean, because there is no medication.
So there's no medication that actually kills or treat the virus, and there's no vaccine. So all this talk about when we get the vaccine, well, if we get a vaccine within 18 months, that would be a miracle, to be honest with you. So what do? Well, you have to prevent the transmission of the virus. So if someone get infected with the virus, you have to isolate them, keep them away from everyone else for a minimal of 10 days. And within those 10 days, if they recover, symptoms are resolved, and they are without fever for 3 days, then we believe that they're no longer infectious. Okay. Now, someone who's been exposed to that person who's infected, We call that a contact. That person has to go into quarantine. In quarantine, the difference between isolation and quarantine is that a person in isolation has the virus. They are a case, they're infected. A person in quarantine has been exposed, or may have been exposed, but do not have the infection yet. So we separate them because, again, they could be infected, not having symptoms, and infecting others. And we keep them in quarantine for 14 days because it takes anywhere from 2 to 14 days for this virus to manifest itself.
Wow. So let's talk a little bit about the recent numbers that we've seen in Shelby County. Last Sunday, 256. Shocking. Only to come back later to see 385 on one particular day, almost 400 cases on Saturday. Were you shocked when you saw those numbers? How did you react?
Absolutely, yeah. Shocked and disappointed because I was hoping that the citizens of Shelby County are really hearing our message of wearing your mask, separating at least 6 feet, avoiding crowds, washing your hands, practicing good hygienes, clean and disinfect areas, because those are the only tools that we have. So somewhat disappointed, hoping that we could move on, but not absolutely surprised though, because when Mother's Day weekend and Memorial Day, folk gathered and was crowded, and when that happens, transmission is going to occur.
Right. So are we seeing impact from the protest, or is this just merely impact from the holidays that have taken place?
I think that this is the holidays and just transmission. We will soon start seeing whether or not the protests had any effect.
Okay.
Keep in mind, think 14 days.
Right.
Right. Although a person can start showing some infection as early as 2. On average, it's 5 to 7. But just kind of think. Now, some promising news is that they sort of did a study in other areas of the U.S. looking at those who were involved in the protests and testing them. I think something like 800 people or so. And of that 800, only 1 tested positive. So that's good news in the sense that many of those who were out protesting at least wore facial covering and masks. And that may even show greater proof that wearing the facial covering or mask is very important in preventing the transmission of this virus.
Okay. All right, I want to pivot a little bit. I have another question that came in about research and research articles. Is there any good work out here that is really solid? And I think this is from someone in our medical community here at the church that really wants to know more about how to gather good information. What do you believe, and what do you cast out and throw aside?
Well, of course, the CDC would be a starting point in terms of looking at their references.
References, okay.
That most times, whatever they write, they're going to reference some articles.
Okay.
Of course, and Johns Hopkins would be another place.
Now, are you saying that because you graduated from Johns Hopkins?
Well, not necessarily, but most people would acknowledge that
Right.
Johns Hopkins is #1 public health in the country,
Right,
although
that's
Harvard
good.
would argue that. But yeah.
Yeah, that's good. Well, Morehouse would say otherwise too, but I'm
Well,
just
and Tuskegee.
And Tuskegee, okay.
Of course.
Of course. We just get that in while we're talking. So with this data, with this information, 8,094 confirmed cases in Shelby County. Talk to me about the 2,400 that are currently active. What does that mean for the population in general?
Okay.
And are all of those people isolated somewhere?
Not necessarily. Let me sort of explain to you what happens when you test positive. So, if you're one of the fortunate ones and you test positive, but you're not sick enough to be in the hospital, okay, which is the majority of the people. Right. Majority of the people who test positive are not sick enough to require hospitalization. They go home and they self-monitor and they isolate, and if they have fever, they treat their fever, and they recover in those 10 days or so, as I mentioned. The health department is notified about all positive cases. We have an investigation team that will call that person, interview them, and find out who all they have been in touch, in contact with. And those individuals who are identified as being contacts, they are also interviewed and instructed to go home and to be in quarantine. And so when you hear some of those numbers in terms of people who are cases, these are some of the active cases. This would be a combination of people who are still at home in quarantine, plus folk who may be hospitalized as well.
Wow. Another question that was asked, and we know that there's been some discussion on this, some that we say yes, some that say no. You've had COVID once. Can you have COVID twice?
That question has not been completely answered yet.
Okay.
There have been reports of individuals who tested positive, got over it, tested negative, then later was tested again for whatever reason and tested positive. Did they get reinfected, or was it a reactivation of the infection?
Okay.
We're still trying to learn which is which.
Okay.
Sort of like the herpes virus, right? You can get an active case of herpes. It manifests itself as the fever blisters. It heals up, goes away, may not present itself for another year. And then when your immune system decreases, it manifests itself. Wow. Fever blisters is a good example.
Wow.
And so you didn't necessarily get reinfected.
Right.
It's just that it's been reactivated.
Okay.
So we don't know if that's the way that this virus is going to work, or whether or not you really get reinfected. Also, there's always the question, well, was the first test correct or not? Right? You know,
yeah.
Because there's some tests, there's a certain degree of false positivity or false negativity. Our hope is that when people get infected and recover, that they have immunity that protects them. That's why we do the antibody test. The antibody test tells us that a person has now proteins, antibodies, that will fight the virus. To what degree, we don't know. How long, we don't know. But the hope is that as we learn more, that it may be that there's people who've already been infected, didn't know they were infected, because their immune system was such that it was able to fight off the virus, and they were able to build up immunity without it manifesting in any symptoms.
Wow. So our guest tonight is Dr. Bruce Randolph. He is with the Shelby County Health Department. I'm going to show you some information that you can find on the Shelby County Health Department website. You can go there and get this information yourself. It has been updated and changed, and we're very thankful for that, Dr. Randolph. I don't know, how you push to get it done, or if it was Dr. Haushalter or whatever, but it's there. It was critical for me and for other members of our community that we wanted to know the race data that was impacting people in Shelby County, because we were hearing these numbers from around the country, and you shared some, and Dr. Haushalter shared some, and I think Dr. Dwight Dishman shared some that was helpful to us. But now it's public, and we can go on the website. And so if you want to go to that website for just a moment, I think our staff has pulled it up, and we can just look at a little bit of it by case. It'll tell us the number of people who are there. That's the case demographic. It shows that there's some young people getting this disease, Dr. Randolph. It shows that the leading group is between 25 and 34 that is being infected. They're not the group that's being impacted the greatest, but they are the group that leads in infections, following by the 35 to 40 group. So that's one of the slides. Go to the next slide. Just as you pull them up, we'll discuss them. That's age demographic. Then there's another slide as we continue to move through them. I think, yeah, there we go. That's the case load, 8,094. The positive number on that screen is we've tested over 100,000 in Shelby County, 2,415 active cases, 5,515 recovered cases. That's good. 210 recent. That's our today's number, I believe.
Right.
Or right there today, we had 210 new cases. So we're coming out of a hot weekend where we had 385 on Saturday, another 210 on today. That's going to put us over the 500 mark just going into the 3-day span, or 3 or 4 day span. And then that death number of 164 deaths, of which about 90 to 100 of them are African American that we recognize. That's the number we want to talk about, because by and large, African Americans are being impacted 2 to 1 in Shelby County, some places as high as 3.6 to 1 around the globe or around the United States. What would you say about just these numbers up here? Where's the hope? Where's the challenge?
Well, a couple things. One is that when we look at those new confirmed cases, we need to look at the rate of increase, right? So we look, it's 210 today, the other day it was 385, the other day, and if we average that, say, over a week's period of time, now we're over 100 and something per day average, right? A while back, we used to be at 50. So it's sort of gone to 50, average of 100. Now, we're getting, over the last 3 days, almost average of over 200.
Right.
So that's something to just keep track of. Yes, when we test more people, you're gonna have more positive, but you got to see what has been that increase.
Yeah.
But more importantly, what is the positivity rate? Of the 100 people that you tested, how many tested positive? What percentage, right? And so when there's a graph that we have that shows that the positivity rate since we opened up had increased from 4.5 to 5 to 6 to 7 to 8, 9, and at one point, I think last time it was checked, it was about 11.
Yeah, it got up as high as 12% at one point.
Right.
Yeah.
And so that's what causes me alarm, because that tells me that there's transmission occurring.
Yeah.
The more people are getting infected. Our overall positivity rate cumulatively is still around 7.4, I think, which is less than the national average, but it needs to be less than that.
Okay.
And it's also increasing.
It is increasing.
Yeah.
It is increasing.
Yeah.
Okay. Oh, wow, that's interesting. Okay, let's put up another slide. I think we have a little bit more information to share on our case demographics. Here is COVID by gender, by sex. It appears as though there are more women impacted than men, about 3,759. About 52% of the cases have been women, and a little less, about 48%, almost an even split. But what would you say on that one?
I think that may be a reflection of more women getting tested,
Okay.
just like women tend to go to the doctor more and what have you. Now, what we don't know, well, what the other slide is going to show really is that when it comes to deaths, there's a higher rate, higher number of deaths among males than females.
Wow.
So you got more cases, but the female tend to get over or recover better than the males.
Wow.
Yeah.
Okay. All right. Next one. Race. There's the big whammy right there. That long line at the top represents cases by race, largely demonstrating that African Americans are roughly 57%, and really because there's a large bracket of 25% that says other race, or sometimes unidentified in some cases, we recognize that that number could be lower, but it's about 57% at minimal for what we're looking at it with African American test cases. Is that right?
That's right. Now, what is also alarming, that other is probably Hispanics.
Wow.
And so when we look at it by ethnicity, I'm looking here now, I think the rate is something like 27%. I remember in the early days, early March,
Yep.
it was 5%,
5%,
or something like
right.
that. And so, and that goes with nationally, that the Hispanic brothers and sisters are being infected by this virus at increasing rates too, especially when you think about what percentage of the population they make up in Memphis.
Right.
Right.
5 or less, I think,
It's
somewhere
something
around
like
number.
that. And a lot of that, I think, is related to occupation. The type of work that they're doing, and the proximity of the work that they do is probably a contributing factor. We want to look into that a little bit more. We need even more, we need to look at the data closer, even when we're looking at the deaths. Exactly what are some of the circumstances, like for example, hospitalizations. What percentage of the folk who show up at the emergency room who get admitted are black versus white, versus what percentage of the folk that end up on ventilators? Break that down by demographics. What percent of the folks? You know, so we get a better picture. The other thing that you have to do when you're really comparing risk, who's at greater risk, you really need to do look at things in proportions, right? You need to actually do rates, so rates per 100,000. So you need to take those deaths and divide them by the population of the group that you're concerned about, and you may find even a greater disparity.
Wow. So there are people sending in questions, and while we're getting ready to put up the next slide, this was a question that came in from Facebook Live. This is a person that wants what's the best kind of test to take for the virus? And so I know from experience, there's one test that has a long swab. There's one that has a swab that's long, but it has more of a tip on the end that you don't have to go as far. Then there's the blood test, but it only determines whether or not you've ever been impacted.
Right.
Tell us about all of these types of tests that are out there, and then we'll put up another slide.
So there are two basic tests.
Okay.
Okay, the PCR, which actually is looking at the genetic material of the virus, the nucleic acid of the virus. And so that's the test that requires a specimen to be collected by inserting a swab up your nose to the nasopharyngeal area, which is very uncomfortable. So now, the recommendation is you don't really have to go that far. You can go sort of halfway. You can go to the anterior aspect of the nose, and you get pretty much the same level of sensitivity as you would, and it doesn't cause as much discomfort and complications.
All right, so as I have been able to discern just from looking at the sinus passages and looking at all, nasopharyngeal is somewhere to the eye or above.
Yeah.
All right, and so below that would be in the midpoint of the nose,
right.
or pharyngeal there.
They
So
turbinate, right? Mid-turbinate. Yeah.
okay, so I don't have to go. All right, so
You don't
one
have
is
to
more
go as far.
comfortable than the other.
Exactly.
Is one more accurate than the other?
Well, if the test is performed correctly, the sensitivity of them are about the same. Maybe a percentage difference or what have you. That difference doesn't mean that you ought to have the more discomfort one for more accuracy, right? It's not worth it.
All right.
Because we can get more people. I think there's quite a few people now who have heard about the discomfort of the test and pretty much are choosing not to get it unless they just absolutely have to.
Listen, we tested this weekend here at the church, and until we put out the notion, I released a little tweet or something that said we're using the more comfortable test. All of a sudden, the numbers shot up.
Exactly.
So yeah, I think that had a lot to do with it.
Yeah.
All right, we're gonna look at another slide here, but I think this one takes us a little bit closer into some other data that we'd like to share and look at. Here are the fatalities. We're getting here and we're looking at the number of people who, out of the 7,000 plus individuals who have been impacted, the oldest patient was 99. The youngest patient was 27. The average age is about 74. So that's what we're seeing on that level. But then there's another slide. Let's go to the next one on fatalities and demographics here. We begin to see by sex, as you mentioned earlier, more men than women. You said that, and that's an accurate piece of data right there. Let's go to the next one. Here we are looking at the age groups. We see fewer deaths, obviously, but there have been a few as young as 25 in that age group of 25 to 34, and then they go up from there. The numbers are higher as people get older, which says that person probably had some of those comorbidities.
Yes.
All right, and they did not recover as well. Okay.
Exactly. Yeah. And there's a couple of things that the slides we have gone through points out. First of all, only 2.2% of the people who get infected die.
Right.
Okay. Which actually for us is much lower than the national average.
That's great.
And in other areas. And then of that 2.2% who died, most of those are 25 and older.
What do you attribute that to?
Well, again, young people respond differently. Their immune system, in general, they have better health.
What about the low death rate?
Oh, the low death rate, I think is a reflection of the quality of our health care. And I think it's a reflection of our efforts to limit the number of people who've gotten infected.
So, and I'll talk a little bit about that. I have seen a very well coordinated effort led by the Shelby County Health Department, Shelby County government, City of Memphis, and the health systems. Every day there is communication and coordinated response. There is task force assimilation and sharing of data, which helps to combat this and really eradicate the virus as well as possible. So I have seen that. Very good coordination. I really say hats off to the Shelby County Health Department for that, because you and Dr. Haushalter began, and I met Dr. Sweat the night before, where he and I stayed at the hospital until 1 in the morning with the first patient. And so literally the coordinated efforts between your team and galvanizing and putting a plan together has been good. So I've noticed that around the country, we have had the impact, but not the death rate. I think there are some cities that mirror the same impact of having 7,000 cases or so, but their death rate is 50 to 60 people higher than ours. And I think it has a lot to do with the coordinated health system response, as well as the health department. So kudos to your team.
Thank you.
Great work. I know y'all haven't been hearing a whole lot of folks say you're doing a good job lately. So the people at First Baptist Church want to tell you thank you for doing a good job. Let's go to another slide. I think that you wanted to say more.
I want to
say more on that.
Too, and especially to the young people.
Yeah.
When that slide about the deaths, right? So, so young folk, they're not dying from it. They're not really affected. But if you notice, the 65 and older, almost 80% of the deaths occurring within that age group.
Let's see if we can find that slide and put it back up there with the age groups up there in red.
Yeah, that's it there. So you look and see that where by age group, and then if you go to the percentages, and we kind of can't see it from here, but you can just see where those deaths are occurring.
Right.
Ages
25% are between 65 and 74. 24% are 85 and older. 25% between 75 to 84, 65 to 74, and 85 and older. So those are large numbers, and then they get into the 16% between 55 and then another less than 3 over there, I guess, and 2%, and when you even get lower than that. So they shrink as you go down, but it is happening.
Right. And the percentage of deaths increases. You know, mortality increases with age anyway, in general, right? But this is another reason why you have to look at your congregation and decide, okay, when we're going to open up and how, and who should be coming back. Because you can see, you know, so if you got a congregation that is predominantly 18 to 35, that congregation is at less risk, certainly of the complications, than if your congregation is primarily 55 and older. Just based on age. And so that's one of the things that I recommend to churches as they begin to look at, okay, how can we return to some gathering? Look at your congregation. Do an analysis.
Very good.
And see what's the demographics, what's the age range. And that way, and then you may want to think out of the box and say, hey, maybe I should have a service for just a certain age group.
Okay.
And then maybe have a service where only just 65 and older at a certain location or whatever. Just kind of, you're going to have to use our creativeness to come up with other ways to worship. Because the traditional way that we used to worship is going to be long and common.
Long and common. Let's talk about that long and common situation. Do you think we are 6 months out, 1 year out from a vaccine? And if there were, I'm put you on the spot with this question, vaccine comes out in January, would you take it?
I wouldn't.
Okay. The doctor said he wouldn't take it.
I mean, but I have to.
You ain't got to say nothing else, man.
Well, I have to qualify that.
In the words of Luther Vandross, this man is a doctor. This man sure enough is a doctor.
Well, you know, I'm slow to take on a lot of innovations anyway,
Right.
because these 30-some years have shown me that something that started out to be the best thing ever, 5 years down the road, we find out it's the worst thing ever.
Wow.
But I would have to look at the data closely before I would, you know, and that's the problem with the vaccination.
Right.
The vaccine. I mean, there's a couple of things. Is one, is it safe? Is it effective? Is it affordable? And will it be accessible? You know, so I mean, in America, we got Cadillac medicine, but everybody can't afford it.
That's important.
Right? It's not accessible to everybody. That's
so
why
important.
those disparities.
Right.
Right? And so, and that'll be the same thing with the vaccine, unless, you know, the government is going to make it free to everybody. Well, you know, the COVID-19 test ain't free to everybody.
Right. Speaking of that test not being free to everybody, someone asked the question, how can I get tested even if I have no symptoms? At the end of this, I'm going to ask our staff to put it out for us, the testing sites that we can find on the Shelby County Health Department website. I know that the Christ Community Clinic is conducting tests right here on our campus. We had a free weekend of testing. I'm sure there will be more, but you can get tested even if you have no symptoms. In the early days, we were encouraging people who had symptoms, but now we're saying anyone should get tested.
Right. And in the early days, that was because there was a shortage of tests and test supplies, et cetera. And then also, you wanted to make sure that your positivity rate. So if you're doing tests, people who have symptoms are more likely to be positive than those who are not, right? Who do not have any symptoms. But now we need to have an idea of how many people just have been infected, period. Right? So we can get what we call the prevalence rate. And so now we're wanting to just test any and everybody, and because of the fact that we know that there are quite a few asymptomatic people walking around.
Right. There's another slide that is obviously going to show us the true impact of what's happening with this death rate when it comes down to race. I think it was the next one following that. I want to put that up, and then we have about 10 minutes left. Okay. This is dealing with the fatalities by race. By and large, even before these numbers were completely updated today, African Americans were leading 90 to 48, roughly 2 to 1, because as we look at other race and then unknown race having 2, that could possibly be included, other race being Hispanic possibly. I have had conversations with the funeral directors in Memphis, and you are aware of this because I talked about it on the call. I think I even sent you an email. And they talked about feeling as if the numbers were even higher from people who had possibly died from COVID-19 and possibly not been notified. And these were primarily African-American funeral home directors. What would you say to that?
That's possible because, unless, so let's say, for example, someone dies at home, and they could have died from COVID, but you would not have known that unless they were tested.
Right.
And it's not a routine practice to test every dead body.
Right.
So it could well have been, those numbers may be underreported.
We just had an addendum made to the death number today, I believe it was, by 11, was it, or 10 or 11, that previous cases or previously uncertified cases have now come back and been certified as COVID-19. Yeah.
Now, the flip side of that, and I think it was New York who was accused of this, that the numbers may have gotten inflated.
Right.
Because on the flip side of that, you go to a home, find a dead body, and you conclude that, oh, it must be COVID. when in fact they could have died of a heart attack
Right.
or died of a stroke. Or even if they've gone to the hospitals, especially since hospitals are testing, I think, everybody up on admission for the COVID-19. Well, so someone comes in, COVID-19, they get tested, found to be positive for COVID-19, but what they came in for was because they was having chest pain, shortness of breath, and had a heart attack and died. Well, that gets coded as COVID-related death.
Wow. So, so Dr. Bruce Randolph, Pastor Bruce Randolph, I'm about to get down to the part that we came for, our faith.
Okay.
How, as men of faith, leading people of faith, would you shepherd me as a pastor? Well, I lean on your wisdom. I call you a lot. I email you. I text you. Because you have the data. You have the knowledge. And I believe you are a man of faith and you put yourself often in my shoes. A large mass gathering, all right? We've seen churches around the country. Some as close as Mississippi, maybe even a few in Tennessee, who've had outbreaks.
Right.
Even when they were social distancing, even when they were trying to follow the rules. How would you guide me on dealing with that?
I think that first you would need to educate your congregation about what does it really mean to be faithful and true to your faith. And you choosing not to come to church when you're sick or ill is not a reflection of you not having faith in God. God hears our prayers in our bedroom. God hears us wherever we are. And so there, you know, though there's joy and benefit of coming among the brothers and sisters and worshiping, God is not just contained here in this building.
Yeah.
God is everywhere. And so I would start with making folks understand that theology of faith, that, you know, you sitting there at home listening to the sermon over the live stream, reading your Bible, that is just as meaningful. It might be even more because you're not distracted by the crayon baby over in the corner. Or you're not distracted by whatever.
Right. That's true.
And so you use this as a time to really get more in tune with your personal relationship with God.
Yeah.
You know, I would also encourage you to you know, let the folk know that if we examine the life of Jesus and what he did, whoever approached him, he dealt with their physical issues first, and before he even dealt with the you know, so the guy at the, you know, the invalid at the pool.
Yeah.
Right?
I know something about him. Yeah.
Right,
Yeah,
right. And many more.
Yeah.
Folks who were blind. He dealt with that. And I say that to say that as a minister, you protecting folks from a virus that can affect their physical bodies is consistent with the practice of our faith.
Yeah.
More importantly, Jesus teaches us to do unto others as we would have them do unto us, and to love others as we love ourselves. Now, I wouldn't want anyone coughing in my face and they know they got COVID or they left home, a husband, wife, brother, what have you, who's suffering from COVID, not coming to the church because they want to get their shout on.
Hallelujah.
All right? To me, that's selfishness.
Yeah.
I would, if you wouldn't want me doing that to you, why would you expose that to someone else?
Yeah.
And those types of things, and manifestation of love is, as Paul, teaches us, do no harm.
Yeah.
That's part of that
Part of it.
manifestation.
That's right.
And so encouraging people to be healthy, to separate, to stay home if you're ill or feeling sick, if you are at risk, is all in keeping with being a good shepherd.
Yeah.
Shepherd takes care of his sheep.
Bless you. That helped me a lot. Bless you.
Yeah.
I'm going to ask you one more question. We're going to wrap it up. The isms of life. We are dealing with poverty that has demonstrated itself throughout this city for many years. We want to make decisions because that's been a dividing line. The number of kids that didn't have computers when this virus hit and all of a sudden had to learn from home who just didn't have the means to do it. Sexism has been a part of our society for years, men and women not earning as much as men and doing the same job. Racism has reared its ugly head yet again. It's been there, it's been talking all the time, but it got real bad here recently. Healthcare, there's this kind of classism thing that goes on. Some who have and some who don't have. As a pastor, I don't want to send a signal to the healthiest and wealthiest in my congregation that you're welcome, and say to the sickest and the poorest who can't get access or don't have testing or whatever that you're not. Would I, as a pastor, send that signal to my congregation by saying, those of you who are sick, stay home. Those of you who have not or cannot be tested, if you whatever, stay home. Those of you who got the card that says you're clear, come on in. Is that consistent with what Jesus would do? Because Jesus said, the sick, bring them to me.
Absolutely.
He brought those people in Matthew 4.
Right.
So are we sending a signal in this society that COVID is about to separate us into classes or groups of people, not just at church?
Right.
Because as I go to the restaurants, I see the people who don't wear masks. I just drive on by. I don't go in, but and then even in some of the places of business, there are some who figure, okay, well, all of us who can afford to be here, we're good, so we don't have to abide by the rules. We get to set our own. What's happening with our society when it comes to that? I'll let you just close us out with your thoughts and take us home.
Well, one thing I want to say is that when people decided on what the demographics looked like, the discussion about when we should open and how changed. And I would raise one question, whether or not the conversation would be the same if the demographics were different.
Ah, wow.
Okay? That's just a question to throw out there, right?
We should have started right there. Right?
But to answer your question,
Go back, Dr. Randolph. Sometimes you have to press rewind. Sometimes when I'm preaching real good, I say, let me hit rewind and go back and say that again because it'll go right over your head. You'll catch it on the way home. But if the demographics were different, maybe it would have been a different conversation.
Yeah.
Maybe the rate of speed for reopening wouldn't have been the same.
I think so.
Wow.
Unfortunately, but I think, we look at the history of this country. I think so.
Wow.
Yeah. I don't think I think that our approach would be different if you had rich white young folk dying versus old black colored people of color dying. That's a reality. That's just the truth, right?
My Lord.
But and so that disparity between the haves and have-nots is going to become even more clear. Even in the area of education, what is happening, and if our community is not very careful, the educational gap that already existed is going to widen even further.
Yeah.
Because as you had mentioned, folk who had a computer online is nothing for them,
Right.
right? But if you don't have a computer, that's an issue.
Right.
We have to start using this as an opportunity to think out of the box.
Yeah.
Even come worship. That's what I mentioned is that, no, you can't, you got to, in some kind of way, meet the spiritual needs of your older congregation versus your younger, and which it may involve having a 65-plus worship service only. If you're over 65, if you're under 65, you can't come. This is for the seniors. You know how they used to have senior day and senior choir or what have you. You may have to do something like that. Or make sure that your live streaming messages, you have some that's specifically addressing their needs and issues to make sure that their worship service is meaningful and their spiritual needs are being met. Because you don't want that separation in God's house to exist. House divided among itself can't stand.
There it is.
Yeah.
There it is. Dr. Randolph, you are a breath of fresh air to this conversation. COVID-19 has had a tremendous impact on us. It has been devastating. We deal with it, you and I know you get tired of hearing it, sometimes I do too, but it's a part of our new norm for the time. But whenever I've talked to you, you've always been enlightening and encouraging, and you've always been factual and down to earth. I appreciate you, I appreciate your faith. I'm so glad to see your faith lead you in this process. I think you are a critical voice for this time in our community, a critical voice to help shepherd shepherds. We need knowledge and information so that we can do the right thing by the people that we lead, and we need it from people who are qualified to share it and know it. I so appreciate you. I thank you for spending this time with us. I know we didn't get to all of the questions. My congregation has a history of waiting until the video is over to start sending questions. I know they're going to start texting me and calling me on the way home and saying, I wish you had asked him, and that kind of thing. But thank you for this time. And if we have to come back, would you be willing to come back?
Of course.
All right.
This has been great. And they can always email me. You got my contact information.
You don't want to give out your contact information to this group of people because they will email you. They will call you at home. They will do it.
Yeah.
But I'll get
But we do have, the Shelby TN website where you send in, matter of fact, it's COVID. COVID at Shelby County, TNs.gov, I think, something like that, where you can send in questions and that type of thing, and me or someone to answer them.
You or someone.
Yeah.
All right. Well, God bless you. I want you to do one thing before you leave. Would you pray for us?
Oh, great. Yes.
Yes.
Shall we pray? Oh, gracious and merciful Father, we come first thanking you for another day, thanking you for another opportunity to get it right. We thank you, oh God, for this gathering here where we're able to not only look at the data and look at the facts as it relates to this virus, but that we're able to fellowship and remember your power. Remember that regardless of how difficult things may be, that we know that you sit high, you look low, and all power is in your hands. And so, God, we just ask that you bless all those who participated through the live stream. We thank you for Pastor Norman and the members of First Baptist Broad. And God, we just ask that you continue to be with us, the citizens of Shelby County, citizens of this state, of this country, and this nation. Be merciful upon us. Forgive us of our sins. Continue to bless us. This we pray in Jesus' name. Amen.
Amen. Man, I feel you coming back to preach for us in here sometime soon. Bless you. Bless you. Thank you, First Baptist, for tuning in on tonight. I so appreciate you. Please share this message. Call somebody. Go back and look at it over and over again. Circulate it to your friends. This is information we need to know. And remember, until we see each other again, we'll be fine again. And until we get together, whatever, everything is going to be all right. God bless you. See you Sunday morning at 8 a.m. on CW30. We missed this past Sunday, but we'll be back on, got everything worked out. And then on the live stream at 10 a.m. right here from the sanctuary. God bless you.